Hi, I'm Ashley Cooley, a birth, baby, and sleep specialist and mom of 3. There's so much information out there, right? This show is dedicated to helping you clear out the noise so you can figure out what will work best for your baby and your family. If you're looking to learn more about your baby, gain more confidence in your parenting, and get as much sleep as you can through it all, you've come to the right place. Bringing up baby is about to get a little easier. Hey everybody, welcome back. I am chatting with my friend, doula, and birth researcher, Kelsey Marr, once again, and we're debunking some myths, and she's sharing what the research says when it comes to baby's due date, as well as what we're hearing about when we're getting towards the end of our pregnancy and we're checking in with doctor or midwife, and we're maybe told we might need an ultrasound because we could potentially have a quote unquote big baby. So we're going to talk about each of these things, what they mean, what the research says, so that you can make informed decisions on your care. So welcome back, Kelsey, and here's our conversation. Can we start with talking about baby's due date?
Mm-hmm.
So from my understanding with due dates is it's based off of the first day of your last menstrual period. There's irregularities with that.
Mm-hmm.
And so by the time we pee on the stick and realize we're pregnant, and if you've been wanting to be pregnant, so you might have been peeing on a stick for a few days before it actually came up. I have not done that before. Then you're like, okay, you're actually already a few weeks pregnant. Mm-hmm. So can you talk to us about this due date? Where does it come from? What are we basing it on? What does research tell us about the due dates?
So the model that most of us use, and by most of us I'm talking like in a Western, North American, European biomedical context, what most of us use is actually called, and I'm going to botch his name, but Nagel's rule. And so it's the idea, it assumes that you have a 28-day cycle. Mm-hmm. It assumes that you ovulate on the 14th day of that cycle. Mm-hmm. And it was come up with based on a study that tracked 100 women's ovulation back in like the 18th century. And one of the interesting facts about it is when the researcher that this rule is named after, when he came up with this system for estimating the due date, what you're supposed to do is take 7 days from your last menstrual cycle, add it on, and then add, I think it's like 265 days or something to get the estimated due date. But in his notes about it, he wasn't clear if you were adding that on to the first day of your menstrual cycle or the last day of your menstrual cycle.
No way.
So later on, like more recently, our obstetrics textbooks have just decided that we're basing the due date off of the first day of your last menstrual cycle. Okay. But that's not actually based in evidence at all. That's just a standard procedure. We just picked one. Okay. And that's how we do it. Okay. So most of us work on that basis of, this is my last menstrual cycle. This is the first day one. Yeah. And then we count 40 weeks or 9 months from that out. And say that is our due date. Mm-hmm, mm-hmm. But we're just kind of pulling that out.
But kind of a educated guess, best guess of as much as possible. Okay.
Exactly.
Well, I guess, we can't be perfect at these things. What's the rate? Do you happen to know the rate of babies being born on their due dates?
So it's actually really hard to estimate how many babies are born on their due date because induction is so common. And whether that's like medical induction where you go into the hospital or they induce you, or people doing things to induce labor at home. Yeah. So I can give you some numbers on where people are statistically likely to give due, but it's hard to say how many actually come by their due date. Yeah. So according to some recent studies, about 50% of women who are giving birth the first time will give birth by 40 weeks and 5 days.
Oh, really?
Whereas 71% who have given birth before will give birth by 41 weeks and 2 days.
Ooh.
So there's actually some research that suggests that based on, like, you are far more likely to give birth 3 to 5 days after your due date rather than on your actual due date.
If it's your first.
If it's your first birth.
Interesting. I've always heard that if it's your first baby, you're more likely to be overdue.
Yeah.
But I had no idea, like 5 days, like that. I was thinking a couple of weeks, or I was like, oh, you're like, that's often why we're induced, is because it's the first baby. We're past that time, and
And it's often, I mean, that's only 50% of women who are giving birth by 40 weeks and 5 days.
Right.
So that means that people are going over, right?
Yeah.
Like a stat is not a guarantee.
Yeah.
There was one study I was looking at where it was like 90% of women had delivered by 44 weeks, which is a weird number. We don't often hear of people going to 44 weeks. Not here. Usually, like, we're talking about induction by 41 and a half weeks, and then definitely induced by 43.
By 40,
But because we don't know, because the way that we're defining these due dates is based on this 28-day cycle where you ovulate on day 14, and we know that's not what everybody does. For people who have longer cycles or who ovulate later in the cycle, or for some people it takes longer for a baby to implant, like, if we can know exactly when that conception happens, which is possible sometimes if you're doing IVF or ovulation tracking, there's like, in this one study I was looking at, they adjusted it, and most people were actually delivering like 40 weeks, 3 days with an adjusted time based on their own conception, even though they might look like they're 43 weeks or 44 weeks or whatever.
Right.
Yeah.
And that's where it really matters and makes a difference, is you get to the quote unquote 40 weeks, and if baby isn't here yet, okay, we got to start this induction talk. But really, you may still only be 38 weeks technically, but there's a range even there of baby being full term and
I mean, there's a range there in terms of what your risks are, why the doctors want to induce you versus what level of risk an individual birthing parent is willing to accept, and what your personal medical history is too. Also really becomes much more a factor in that conversation about induction than, you know, this pipeline that we often follow allows for.
I can remember for our first child, we had spent a few years trying to have her, and there were some losses, so it was I think maybe I know when it happened kind of thing. With our second daughter, I don't know this to be true. How could I know? However, there was a day where I felt something, and it happened to be what I thought would be around when I would ovulate. And again, I was never really very precise with my cycles until after I had babies, which is very interesting, but not what we're talking about today. So I remember this day of being like, I felt something in this particular area, and is it ovulation? Am I feeling that? I'm going to test it out. So I literally, that particular day, called the husband home from work. No, but like, things happen. Okay, we all know. And I just decided I'm like not going to do anything for the next few days. Like, let's see. I was just really, really thought this could be that moment. And we actually also assumed that we were going to have to try for a while again to have a second, because that was our experience with our first. And lo and behold, luckily we didn't, and bam.
Yeah.
And I know the exact day and all the things. I think I do. Anyway.
Yeah.
All that to be said, when I do discover that I'm pregnant and I make a doctor's appointment, and I did get dating ultrasounds, where it's in the first trimester. It could have been around week, I don't know, 6 or 7 or 8 or something like that. And when they give you a due date based on that, that ultrasound, or any ultrasound that you have, but I'll ask you more about that in a second. I remember when they said, oh, so this was your due date. And I remember being like, no, it's not. Like, it's actually this date, because I know I could tell you.
Yeah. But
then you're like, oh, well, they're pretty close together. And then you have another ultrasound. If you've had one early on, not everybody does, but most people certainly have one at 20 weeks, the anatomy scan. And then you get a different due date.
Yeah.
And so I'm like, okay, I have like 2 or 3 due dates here. Which one am I using? What do you do in that situation?
Yeah, I had a similar experience with this pregnancy, because I had a pregnancy right before this. I miscarried. I didn't cycle in between. And I know what day I was sexually active, right? So I have an idea of when I conceived. And when I went in for my dating ultrasound at 9 weeks, because of the miscarriage, they adjusted my due date so that my conception is before I miscarried my previous pregnancy.
Oh, because you didn't have a cycle.
Because I didn't have a cycle in between. So right now, my estimated due date is based on a date where it doesn't make sense, because I miscarried after that.
Okay.
And I mean, that has to do with, the way that the baby measured at the ultrasound and, the intricacies of this rule that we've decided we're adhering to for due dates. But I mean, that just gives you an idea of like, these are made up numbers, right? Like they're not necessarily going to align with your personal experience of what your body is doing. That said, in terms of like having all of these different ultrasounds that are done before 16 weeks, so those early dating ultrasounds are a lot more accurate in terms of your estimated due date. And actually, the American College of Gynecologists, Obstetricians and Gynecologists, ACOG, recommends that if you do get like a 3rd trimester or a later ultrasound or anatomy scan, that unless a previous due date wasn't assigned for say you didn't have any other ultrasounds scan, or that the estimated due date is changing by more than 21 days, you don't adjust it. Because that earlier ultrasound is so much more accurate than the later one in terms of baby's due date. And that has to do because early on in pregnancy, early on in fetal development, most babies, most cells, most masses, we've actually been calling our baby cellular mass, because when we first found out about them, they were just a cellular mass. But yeah, so early on in pregnancy, they're all about the same size. They just, you know, they divide pretty like on a pretty standard curve. Later on, there's a whole lot of other factors that that determine how fast your baby grows and how big they're gonna be, right? So like if you have factors that are going to lead you to having a bigger baby, like genetics, like gestational diabetes, like those things, that can actually lead to baby showing up on the anatomy scan or on a later scan as bigger, as you know, further along in their development, whereas they're not further along in their development, they're just a bigger baby. And likewise if they're showing up small. Right. You generally, and I mean, this is getting into the topic of big babies, but generally, based on an ultrasound, there's about 30% kind of estimation gap in how big that baby is. So, you know, it could be 15% bigger than your baby or 15% smaller than your baby actually is.
Looking for the best for your baby? Atlantic Canada's Baby Store is here for you. Nurtured, which is right here in Halifax, Nova Scotia, has the best products for baby. The staff are so incredibly helpful, and they have the most top-rated car seats and strollers you won't find anywhere else. So whether you need expert advice or the perfect baby gear, Nurtured's got you covered. Nurtured, supporting your parenting journey every step of the way.
We're going there anyway. Big babies, and that is part of. Again, I hear about it a lot because I teach prenatal classes. But we all know, or if you're pregnant, you may know by now at doctor's appointments or with a midwife, they're measuring the stomach, and it usually coincides with how many weeks you are. Correct. So oftentimes in third trimester. Maybe we hear, or somebody comes to class and they're like, oh, well, this is my due date, but apparently we have a big baby, so we'll see what next week's scan brings, right? I might need to be induced, or I may need, and I am aware, or have been aware of this variant of how big they're saying someone's baby is, and then when the baby actually comes out, are they ever right? Like, I don't think so.
No.
But that would be a scary, I think, if that were me and I was pregnant and I'm thinking, okay, we're having a baby, and I go to an appointment, it's like, oh, actually we're going to see how baby's doing. We think baby might be measuring big, get a confirmation of some kind, like, yes, your baby's measuring X number of weeks, so you may be delivering sooner, or we may induce. For people who are thinking or hoping or wanting a vaginal delivery, that's where we thought, oh, well, do I need to be induced? Should I do this? Is it because if I don't, my baby's going to be too big? I'm going to need to see, like, it brings up so much stuff.
Yeah.
So there doesn't seem to be a whole lot of, like, well, when you say there's like a 30% difference, like that, I don't have a lot of faith in those scans, but that's what we're using. So what is one to do?
Well, and I think it depends on, like, the first thing to address is the fears that people have around having big babies, right? Like, there's this fear that I hear from my clients around, if baby's too big, I can't have a vaginal birth because our head won't come out.
Or it's going to be longer, harder.
Or they're going to get stuck.
Yeah.
So when we're concerned about baby being big and having a vaginal delivery, we're not actually concerned about how big their head is. There's not any research that I was able to find that shows that baby's head can be too big to come out vaginally. What can be of concern, and what sometimes you'll hear the doctor say, is we should consider induction because is shoulder dystocia, which is when baby comes down and their shoulder gets stuck, usually on, like, the pelvic bone. So their head is out, but the shoulder's stuck. Now, having an induction, if your chances of shoulder dystocia with a big baby overall, and
you're using air quotes.
I'm using air quotes on big baby, right?
I use air quotes a lot on podcasts, but I gotta say,
because, like, what is actually
a big
baby? Big baby, right? Like, I mean, you could say a big baby is, 9 pounds, or for some people their 8-pound baby feels huge. I've been at births for babies that has weighed 11 pounds. Like, that's a pretty big baby, but, like, it's all relative.
Yeah.
It's all relative, right? But your chance of having shoulder dystocia, which is our major concern with big babies, overall is 7 to 15%.
7 to 15?
percent in the general population.
Okay.
So that's depending on what you feel your level of risk is that you're comfortable with, 7 to 15% is relatively low. That said, having an induction because your baby is big may lower that. If you were at the 7% risk factor, it may lower it to 4%. So you're looking at a 3% reduction in risk for that for shoulder dystocia in particular.
Interesting.
Which is not...
And that's the main concern.
And that's the main concern with a big baby. So part of the reason why shoulder dystocia is of concern is because if, baby gets stuck, doctor assists them. Usually it's no big deal, right? Like doctor assists, they get the shoulder out, we move on. There can be some concern about NICU stay if baby has shoulder dystocia. Some concern about nerve damage in baby's shoulder, but induction hasn't been shown to lower either of those risks. So those risks are whether baby has nerve damage in their shoulder from shoulder dystocia or ends up going to NICU. Both in terms of a big baby, both of those risks are not being impacted by an induction. They're going to stay the same as if you did not get induced for your baby.
That's very interesting because whenever I hear someone in class say what I'd said earlier, like, oh, baby's measuring big, so it looks like it's going to be sooner. Are people being told, like, what, like, it just seems like, oh, you're having a big baby, so we want to get this baby out because it making the assumption you're not going to be able to have your baby vaginally if we wait. I find it interesting that even the induction doesn't lower those, but I do hear or have heard, and maybe you can clarify, that a baby or a fetus in the womb, they grow faster towards the end of the pregnancy, so that those last couple of weeks, it's like, hey, if I have a quote unquote big baby and I'm 36 weeks, how big is this baby gonna get if I don't induce? I think is where it comes.
They put on a lot of their development in terms of like organ development and stuff is going to be done by 36 weeks, but they put on a lot of weight, like bodily mass, between 36 weeks and 40 weeks, right? Like if you see, in my experience being at birth, when somebody gives birth at 37 weeks versus 40 weeks, baby looks slimmer at 37 weeks than a baby that's reached 40 weeks gestation. That said, we're also making those estimates on having a big baby in a big window of
what's normal.
What's normal, and what readings are we actually getting on this baby's size. So, I mean, if you're measuring big at 36 weeks, there's a chance that you're big, or there's a chance that the reading is off by up to 15%, right? The American College of Obstetricians and Gynecologists say that that more research is actually needed to determine if a suspicion of a big baby is a significant enough reason for an induction, because induction itself is not without risks, right?
Yeah.
Like once we start the induction process, whether we're doing it with meso or Cervidil or Pitocin, like we know that there's a cascade of interventions that come with that. If we start an induction, we're much more likely to go to epidural. If we go into epidural, we're much more likely to go to other interventions. So like knowing that risk, even the American College of Obstetricians and Gynecologists, who are, fairly, I would consider a fairly reputable source, they don't necessarily think that an induction for a big baby is what would be recommended.
Yeah, interesting. Yeah, it's feels like one of those things where it could go either way, and it's almost like what are we feeling we want to do?
Absolutely.
And but I just feel like, and why I'm glad we're talking about this and you're sharing these stats, is we're not necessarily making informed decisions because we're not given all of that information when we want to make a decision. We're given, you have a big baby, we could induce next week, or you could hold off for a couple weeks. I don't even think they say that. It's just like, this is what we can do for you.
Yeah.
And then you're like, okay, I gotta choose. But we need to know these things. If you're telling me it was going to be like an 80% chance that my baby's gonna have shoulder dystocia, like, okay, that's a pretty high percentage. But 7 to 15.
Well, and if you're looking at C-sections, I mean, if your baby is over 11 pounds or greater when you go to birth, it would take nearly 3,700 C-sections to prevent one case of shoulder dystocia. Based on that.
On that research. Wow.
On that.
Wow.
So, like,
that's another way to look at it.
Like, is going to, like, if you want a C-section because your baby is measuring big and you feel that's the right choice for you,
great.
Absolutely.
Yeah.
But if you're doing it because you're thinking that this is the way to prevent shoulder dystocia, well, you'd have to be there'd have to be 3,700 unnecessary C-sections
for that one.
Statistically.
See, this stuff's important to know. It's so important to know. That could change somebody's mind one way or the other, which is, there's no wrong answer. It's whatever that person decides to do, but they should have that kind of info to make that decision.
And unfortunately, just our system's not set up in a way where unless we go looking for this information ourselves, we're not necessarily going to be provided with it just on our journey through the medical system. Yeah.
And I think that's where I got caught up, and why I do what I do now is I thought when I was first having babies and having my first baby, it's like, oh, you go to the hospital, they're going to tell you what to do. Like, because they do this all the time. Oh, someone's going to direct me. But it doesn't quite work out like that. They have a job to do and they're here to help, yes. But the decisions are yours and the information is yours to find out, and all of that stuff. Yeah.
And sometimes you need longer to process the information or to figure out how the information fits for you than you necessarily have in that space, right? So if you have an opportunity to look at this information ahead of time, then you also have the opportunity not to make a split second or spontaneous decision based on that information.
Or have your own questions to bring back to your doctor to those appointments. Yeah.
Exactly.
One more question about due dates I want to come back to. We were talking about this earlier. Not everyone gets those early ultrasounds in the first trimester. And so what if someone's first or only ultrasound is that anatomy scan, that 20-week scan-ish, and they're given that quote-unquote due date or estimated educated due date? Should we shave off some time on there, or like we'll just have to use that as our kind of guide because this is the only one we were given?
I mean, I would use it because it's the only one you're given. I would use it as a guide. But I also think it's important to mentally, like as birthing people, to mentally move away from that estimated due date and to think more in terms of an estimated window. Like when I went in for my dating ultrasound a few weeks ago, I was actually tempted to ask the tech not to tell me the due date so that I wouldn't know.
Don't confuse me. I know what's going on.
because statistically, baby's not going to come on their due date. But I see a lot of my clients get hung up on that due date. So you do need to like plan within a window to the extent that you personally feel you need to plan or have things organized or buy things or whatever. But also sometimes that due date can cause a lot of stress. Like family will text and ask like, is baby here yet? If you go late, I see people get very, very anxious if they go past their due date because
each day that passes,
they just want to, and understandably, you've been pregnant for a long time.
You're probably done at this point.
You're feeling done.
Yeah.
But they get very anxious about it. Whereas if we can kind of try to reframe and instead of saying, for example, my baby is coming August 11th, instead say my baby's coming sometime the end of July or the beginning of August. I find that gives people more mental relief around it. Like you're still planning for a window. They're going to come sometime between 37 and 42 weeks statistically.
So we should have a do month.
A do month.
A do month.
Right?
And
like,
for that month, whether baby's here or not, you're
just doing your
here.
thing.
Yeah.
Right?
Yeah.
Take the stress. Because, like, if you work yourself into that mental stress of, like, I'm so done, I'm so tired, I just want this baby to come, then you're walking into birth with that. And we know you don't get a break after you birth. Like, you're exhausted and you've run a marathon and you're on to the next marathon right away. So, like, if you can not carry that mental load beforehand, it just seems a lot easier.
100%. And hopefully this episode will take some of that pressure, that weight off of people's shoulders so that they can do that now that we know what the research tells us. Amazing. Thanks, Kelsey. Let's talk again.
If you're looking for more information or support along your parenting journey, check out birthbabysleep.ca. That's where you're going to find prenatal classes, postpartum and new baby resources, and sleep support during the childhood years. Lastly, but certainly not least, if you got something out of this episode or our show in general, leaving a rating or a quick review goes a really long way to helping others find us. So please consider leaving one. That's all for now. I'm Ashley Cooley, and we'll see you back here next time.